Welcome everyone to Planetary Health First, Mars Next. This is Jam Out Justice, Justice Jam Out. But not only is that Justice Jam Out, we're going to be jamming out. We got some amazing guests here, a rock star, Susan, rock star, IT rock star, and we got Melissa here, and they are really super passionate about Justice Jams and everything about making, healthcare better in the justice correctional systems. And this is part of our new series, Bring a Friend. And yes, they are friends. And if they weren't great friends, they're going to only be better friends. You get to be better friends by spending time together, and they're sharing these topics because they're passionate about it. So we would love for you to hear a little more about this on this video real quick.
Been incarcerated for a very, very long time. And over them years of incarceration, it keeps you locked in yourself. You don't have trust, relationships. The Realness Project is a way to come out of myself. Gives me the opportunity to understand that I'm not in this alone.
The experience in the groups was peaceful and growing and warm. And I feel like I went through about 6 months of therapy in about 40 minutes.
I'm a father of three, but I'm a grandfather of 17. And with the Realness Project, it's giving me the tools and the means to help mold and teach my grandchildren to break this cycle of incarceration.
A lot of youth, we are taught to express ourselves through our fists and through profanity. With what you teach, we can talk a person down. You know, a lot of us want a way out, but when we feel like we don't have a way out, we do what we know. Authentic relating teach us how to connect with our feelings and express our feelings.
It's time to make a change, boy. The time is now.
Realness Project is very crucial work to learn there's other ways to be free, whether it's in prison or in the communities or whether it's with children. My life is not a waste.
I am worthy.
I think it's fair for me to say that the reason I'm in prison is because I didn't know how to be authentic. So programs like the Realness Project being free, it looks like listening. It looks like being courageous enough to be vulnerable.
If the Realness Project was to be touched down to the juvenile centers, it would help open up a lot of people's eyes. You know, all this time I could have been just being me.
I believe everything's about relationships, and whether those relationships are healing or building and contribute to the community, or whether they harm the community. We need programs like the Realness Project, so we can't if those resources aren't available.
All right. Well, we have Susan Clark here. 1 second. Sorry. All right. You should be able to just hear us. No more background. Anyway, we got Susan Clark here, the health IT rock star, and Melissa. And take it away. You guys are the experts here. I'm just trying to facilitate some great conversation.
Okay, so I'm going to start with an introduction. My name is Melissa Denino, and I work for Incena. And Incena has provided the opportunity for their individuals that work there to dedicate 10% of their time to their passion project. And due to that, I was able to delve into my said passion project, which is incarcerated individuals and the healthcare system. The clip that you just provided was from the Realness Project. And I am on the community council for that organization. And what they do is they're located in Colorado, and they go into maximum security state penitentiaries, women's centers, and they work on habilitation for the members and the individuals within incarceration to be able to better communicate have skills that not only will help them in the outside world upon reentry, but as well as being able to communicate in-house and develop relationships that they might not necessarily have known how to do prior to being incarcerated.
And I didn't know about that until I heard her talk about it on another podcast show, the Health Tech Talk Show, if you haven't heard of it. And then I said, oh, I already thought Melissa was cool because we did similar things, because I guess I should perfect place to introduce myself of how I knew you before was I currently work for Direct Trust, and that is an organization focused on trust in healthcare, privacy, security, and interoperability. Direct secure messaging is what their like claim to fame is with the standards organization. And we're just trying to push forward trusted information and being shared, which we'll come back to. But prior, I did a lot with statewide health information governance, Medicaid, health information exchange, which is why I knew Melissa, because that's similar in her day job. So we thought, oh yeah, she's super smart, knows lots of cool stuff. And then I saw this and I went, oh, that's amazing, because I got to touch a little bit of corrections work when I was working with our state in Indiana on some Medicaid technology projects, and how can we make this better, and really getting to talk to folks that work in the system and understanding what gaps we have, which I'm sure we will get into here. But that's where my passion is that we have it just such a broken space of that we have focused so much energy thinking of, day one meaningful use and promoting interoperability, so much energy into hospitals and what we call traditional healthcare provider space. And there's all these pockets of very important care happening that are kind of just not thought about in a lot of spaces. So that's why I get very passionate about it, because these are people, and they're people I've known. So that's also why I know people who have been in prison and in jail in some very unfortunate circumstances, and they are good people. It was just, that's what happened in their life. And they don't deserve any less than I do when they come out into the world.
So I put on the screen 78% of the people going into incarceration systems come back out within a year. Man, we got a problem here.
Mm-hmm.
Yeah, that number is extremely high. And you also have to realize that those individuals are not only coming out of the system with whatever issues that they went in, but also compounded by health disparities within the system. They're not getting their A1Cs checked on, they're not getting the mental health that they require, they're not getting the substance use disorder initiatives that they need upon release. So a lot of them fall back into unfortunate ways. And some of those situations are also compounded by the fact that the homelessness issue is out there, and those people are not being connected to the correct community officers or community organizations in order to stop that from happening.
So what are you, what would you like to happen in this conversation? What is the takeaways you'd like to see, Susan and Melissa, if we could get the message out here today?
Well, I will actually reference, I want to give a nod to also how I got very passionate about this to Dr. Kristen Doss, who is the former chief medical officer of Indiana Department of Corrections. And she had, and now works for Core Civic, so has a different national viewpoint, but okay, making sure I can only see me. I was making sure I was still on. Like, oh no. But yeah, that
is intentional. We're allowing you to have a lot. Just go for it.
Oh my gosh. I went,
yeah.
oh no, I've disappeared, fallen off the face of the earth. But anyway, so I actually, in preparation for this call, talked to her the other day, and I'm like, what should be our takeaways? And I couldn't say it better. She said, don't forget them. Simple, like that. And I would like to carry that forward. That, again, it's a population that and if you want to kind of take more of the healthcare ecosystem, healthcare system frame on it, on top of the just humanitarian, that like care about people sort of thing, that we're putting a burden on our healthcare system. It puts a high cost on the duplications of care, that we're not sharing information. A lot of times our like the Medicaid managed care entities are actually now really getting involved in this. So we got to give some credit out there. I mean, they have been a forgotten population in some cases, but the attention has grown, and there are a lot of entities trying to do better reentry of programs, which I think Melissa can speak more about, but of how do we share this information? So my takeaway is, when you're looking at any form of interoperability, any form of information sharing among the healthcare and social care communities, that don't leave anyone in the correction system, justice system behind, as far as technology, infrastructure, resources, support, because I don't think that's there right now. That even the ones that have an actual electronic health record, may not even know what it's capable of. They don't know direct secure messaging is a thing. They may not be even if they have a really top 5 EHR, they may not have the most current version. They may not have a team that can look at what those opportunities are in there. So how do we reach out? How do we reach out and bring them into the health IT conversation as part of the regular conversation?
To piggyback off of that, I just want to state that jails and prisons have historically developed separately from the broader healthcare system. So unlike prisons, there's no federal oversight of those jails in the same way as there is for prisons and for Medicaid specifically. So the disconnect has led to challenges in integrating county jail systems, both regionally, and impacting the continuity and quality of healthcare for the incarcerated individual. And to also point out what Susan was saying about Medicaid and all of the things that they're doing in order to try to, break into this realm. There are currently 17 states that have applied for the 1115 waiver for justice-involved individuals to receive Medicaid between 30 to 90 days prior to release. So that would allow those individuals to not only get their Medicaid situated and handled and have their ID information, but also have that population have a care coordinator and be able to have all of the necessities provided to them prior to release, so that when they are actually in fact released, they have that medical health provider, they have that substance use provider, they have that primary care provider that would be necessary for them in order to, keep out of the system, because all of those things genuinely affect the impact of them returning back into incarceration. I know that New York just passed a waiver for healthcare related social needs, and it specifically entails unmet needs related to adverse social conditions, and jail population is included in some of that language.
So awesome. That is a huge difference, because when I first got involved and learned, it was still getting schooled on how Medicaid technology funding worked, how waivers worked, all of those things, was when I first really understood part of their isolation is in many cases that they have no other payer involved, and especially no governmental payer who has the regulations that Melissa mentioned. So if you're not under a Medicaid payer system, you don't have to abide by all of these same, all of the stuff that I post about all the time from ONC and CMS on health IT. They don't have to do that because they are not obligated to that payer system. So I'm very excited about what you just mentioned, because that gives Medicaid an opportunity to be a better resource, be a better partner, and say, we do want this information to move. We do want this data to be better. So how do we support that?
I also was excited, Melissa, when you shared some of the resources about the advocacy, the organizations that support reentry. Do you want to mention any of those? Should I bring up some of
Yeah.
those? I was one that came to mind, I thought was really cool in San Francisco, the last mile, that really helps people tech careers and coding and developing. Is there anything else? I just, that to me really excites me, because in the end, if you don't have a purpose, if you don't have any skill, you're not going to do too well. You're going to get back right in the system. You're going back to your old ways.
So recently I came in contact with an organization, or learned about an organization called the Osborne Association, and they are specifically engaged in the Elderly Reentry Initiative. And what they do is they partner you up with an individual and a mentor in order to get back into the workforce, amongst other things as well. So like, they do find you healthcare, they help you with resumes, as well as helping you generally get back into the workforce. Also, there's another, I know that we were speaking specifically about workforce organization, like assistance in the workforce. However, I wanted to also touch on COACHES, which is an acronym, Community Oriented Correctional Health Services. It was founded in 2005. Susan, I think that you would find it remarkable. There's a gentleman there by the name of Dan Mistek that I regularly bother and irritate to find out stats and information. And he's a plethora of knowledge. And he's also helped work on building connectivity between jails and community health centers, and specifically of organizations within Massachusetts and Camden County, New Jersey. And within Camden County, New Jersey, they have their own reentry program where they do help facilitate those workforce reentry methodologies in order to make sure that those individuals have a way to go about things.
So I'll just ask my own personal interest question of, so then are there health information exchanges involved in that? Are there like, how are there intermediaries, or how does it work?
So Camden, I know, is specifically working on a reentry with a closed loop referral program. I am set to speak with them next week, so I will have more information, as that I am a New Jerseyan, so it's near and dear to my heart, and that population is extremely impoverished. So they do have a closed loop referral that goes within the hospital system and then brings them right back into the jail system. So there is some type of technology working out there. I'm not quite sure as how extensive it is, but I will be finding out more. But to boot, Colorado, in some of the jail systems, they do a numeric coding of 1 to 5 on, say, like mental health disorder or substance use disorder, 5 being the worst, 1 being the best. However, when they're released, they're being released with that number, and that might not necessarily be true to standing once they're out in the population. So they're trying to navigate and how to work that out.
Now you hit my happy place. I heard that I'm hearing standards, that maybe is an opportunity for education. I actually was going to bring up too that I go down rabbit holes all the time. Give me a topic and you'll lose me on the internet for an hour, and it's a blessing and a curse. That after I talked to Dr. Doss last week,
I knew I loved you.
So my adventure after talking to Dr. Doss was, she had told me about the National Commission on Correctional Healthcare. I'm like, need to know about that. Like, when you think you know everyone that's got a conference in the world, no, you don't. But when I looked at it, and I so welcome anyone from this organization to reach out to me in case I don't get to you first, of that it feels like it's a lot around the practice standards, operational standards, quality, clinical, and I don't see a whole heck of a lot on technology. And I even went, looking at their conference agendas, and like, this is a real opportunity. Like, this could be, and I'll maybe go back to you, Melissa. Do you have any thoughts on how we grow this as a use case among our, vast networks that we have?
I mean, I know at this juncture, there's a way for MIPS to somehow be, we just did that thing where it's just me now. I do know that there was some conversation when I spoke with coaches about how MIPS can somehow be incorporated into the jail systems in order for them to get some type of EHR to have standardization, but I'm not really sure as how far that's going along. I know that it's being emphasized a lot. SAMHSA just had a huge webinar yesterday on the elderly population in the incarceration space and the statistics that they were providing. So it's obviously getting, press and it's being pointed out. So hopefully within the upcoming years, with the waivers being passed, there will be more standardization for that data to be exchanged.
Which then makes me go to, sorry, now you got me going. I feel like I'm getting
Sorry.
faster as we go. And
Slow down, we have an hour.
So I had like 4 thoughts at once, but one of them was because of what we have historically dealt with in our more traditional systems of around CFR 42 Part 2 and the higher confidentiality protections, and what does that look like for exchanging data in and out. And I don't know all of the federal standards that govern prisons for information security, so that would be another adventure down an internet hole for me. But of how, and especially if you think of maybe down to like county level jails, especially maybe not as much as a federal prison, of what do we need to do to also ramp up their protections of their data and their systems before we get sending it all over the place. So that was just one thing that popped into my head. Have you seen anything on that?
Not in my research, I have to say. That's a good point. I have nothing to say about that. I just I feel like you made a good point.
Yeah, no. Now we're just opening the door for people to inform us. Like let's learn.
Well, I know most organizations have a CIO in different roles. What kind of technical roles do they have at prisons to make sure anything's getting done? I would say fairly few, right? I mean, that would be frightening. I mean, if you don't have someone on the ground really doing it, administrator, even a help desk support, curious to how that looks.
My limited view, so take this at an N of few, of just in my state, just thinking of, especially from state level and depending on the state and how it's run, but that it's usually like Department of Corrections at the state level is thought of as corrections as a whole, and their healthcare is not thought of, and therefore they're resourced with generalist technical people. So there's not that extra understanding of what it takes in that regard. I mean, I guess the upside would be that they have to comply with state standards on security and technology, which I know, just looking at our governor's agenda for this year, that is a priority, which yay, cybersecurity statewide. But so there's that. But then at the county level, again, I went to an opioid summit a few years ago where I sat at a table with some county organizations and a county sheriff, where he's like, yeah, we don't have any, we have paper, we don't, because I was asking about his recidivism rate. He's like, we don't know what it is. We don't have that documentation. Yeah, we don't have that data. So like it's so widely, because I would, and then the other end of that, I'm thinking like Core Civic is an example, probably like a Centurion, some of those national vendors that administer, that oversee every all the aspects of the care in the prisons, like they have economies of scale. So I expect that they would have more of a CIO, CTO, CISO, but I don't know that. So I think it's widely varied.
I mean, the ones that I have spoken to do have, for the most part, have separate records for physical and behavioral health. And, there's obviously on the prevalence of outdated paper records. So the challenges related to firewall issues, those are all things that would need to be contemplated and discussed prior to putting into further action.
So I have to ask, because it's the hottest topic, since 2 years ago. how far do we have to go until they get to take advantage of TEFCA?
I mean, Tefka's now real. You know, Q-hins are
Right,
real.
right. I had to poke the button.
Q-hins are now real, so it's a thing. So
Yeah. And I mean, it is a treatment, and I just really, I guess that's a great question for our friends that are part of the real Q-hins, and like, I would expect it would just be a participant in the umbrella of, you know, like looking at the, I always picture the Sequoia
the
RCE
yeah,
umbrella of
I know
the
which one you're
participants
talking
raining
about.
down.
Well, I don't mean to be so ignorant, but I feel like one of the big things that might drive success with the correctional, you know, with healthcare is the Medicaid managed care enrollment, and the fact that they want to have all that data, all that demographic information to quickly get them in. I mean, I hate to say it. I would hope that would accelerate it, just from, unfortunately, a selfish, you know, economic point of view of getting more members on their plan. And maybe, like you said earlier, Melissa, that they're doing a better job, different organizations, with that 90-day reentry, getting them enrolled. So I hope something like that would happen with standards within that, maybe.
Yeah, well, California and Washington are the ones that have just recently approved those waivers. So I believe California is 90 days, and I'm not sure what the Washington followed. But it's at a bare minimum of 30 days prior to reentry that they will be getting Medicaid benefits.
Oh, that is a very great point. And I have two things. One is you have to sell on the either the profit or the cost, like, or the cost savings. Like, it's just, that's where we live. We are in that world where we have to demonstrate that beyond the clinical and human value, that there is a cost savings.
ROI.
Yeah, there has to be an ROI. But just thinking California, kind of a shameless plug that I am going to be hosting a panel of the newly designated QHIOs with the California Data Exchange at the California Health Information Association meeting in June. And you just gave me a great idea to add to my questions for like, is this on the roadmap? I mean, I'm sure it's all new, but that would be kind of a neat thing to hear, because I mean, I don't know California well enough, but I can only imagine how many justice involved individuals they have, and that this probably is worth talking about.
I can't wait to hear the answers.
So what my biggest concern is what is happening now, really diving deep. Like, what is the basic level of healthcare currently at correctional facilities at this point? You know, what is, you know, do they have a nurse practitioner? Does a doctor come once a week? You know, what kind of medications, what kind of physicals done? I mean, I know, Melissa, we talked the other day offline that, you know, the foods that they're being served and given is just really like, let's get you diabetes real fast.
I was going to say, yeah, we're just contributing to the existing problem and actually perpetuating it instead of resolving it, and then sending them out with absolutely no physicians or care, you know, and then compounding it with an additional problem. Now we have hospital readmissions due to diabetes or whatever the case may be. And then, you know, obviously the statistics are there. They end up back incarcerated. So on top of, now you have all of the ED visits, you have the reentry population. So we're just accumulating costs. Obviously, we have to be able to prove the ROI, like Susan said. I just don't know how to go about doing that. Obviously, it's being spoken about to some extent, but it's obviously not resolved. We have some ways to go.
Yeah, I have a couple thoughts to that. One, kind of both extremes. One being, and mentioning, you know, the older population that you talked about, Melissa. That, I mean, some of these larger facilities have working hospitals, essentially. Like, they are full service I don't want to discredit them as being, like a, Band-Aid station, that they have full working clinical services. And the other side of that, I think of, going back to my yesteryear when I used to work in clinics in a rural setting, like the folks from city, county jails bring the prisoners to, right to commercial, our standard healthcare type facilities, because they don't have anything in-house, which takes an immense amount of resources. It's uncomfortable and awkward for the individuals, and like, because they come in shackles, and it's kind of heartbreaking once you think, thinking of when I was younger, it was just like, oh, someone's coming in and handcuffs. That's but now, as this point in life, knowing all of these things, I'm like, oh, that poor person having to be put through that. And now we took 2 officers out of their normal job to have to bring them to this clinic. So I think it's a widely varied, Michael, on and I guess going to the, under-resourced communities, rural, remote, I would imagine, our tribal, island, like, I would think that would be even harder.
Yeah, I'm thinking telehealth. I'd like to know if they're using telehealth solutions. Really, the 2 areas that I think are huge. I mean, substance abuse situation and behavioral mental health. Like, what's going on in the prisons to mitigate that, improve that amongst the population.
I mean, up until recently, MAT wasn't even provided in most settings. So methadone-assisted treatment. So that's a huge thing right there. And to touch on the point about the population that Susan was speaking about the elderly population, I think the stat is like somewhere around 2030, 1/3 of all incarcerated individuals are going to be over the age of 55. That's a huge number, and those are also compounded by additional health disparities as the population gets older.
Telehealth. I was like, what was the question? I already forgot because I was thinking about what you said.
Because I went on my tangent.
Yeah,
well,
no, it was good.
Susan, I'm waiting for the rock star, the health IT rock star, to take the lead so I can put you on the single screenshot. Okay, that's the next thing I'm waiting for. So we want you to just take the lead. Do you want to do the telehealth lead where you tell us all things prison telehealth, your thoughts on that, and I can put you on the screen?
You can put me on the screen, but it's not going to be a really long talk because I say, absolutely, that makes sense. I mean, that's how shared resources is. So I'm all for telehealth in all kinds of settings. But I did happen to see in my meanderings of the internet on Friday of and I don't remember if it was like the National Commission on Correctional Health, or if it was from CoreCivic, or it might have been. Anyway, some organization had a whole press release from within the last few months of how they are leveraging telehealth. So I know it's there. I know that there's a recognition of the value. And again, it's got to save money. It's got to save resources. It's got to save to have it there. And although my mind just went to, again, is it secure? I couldn't help it. It went there. But yeah, how are they actually securing and transmitting and documenting? Because then my health information background goes, how is it documented? How is it? There's so many questions.
So Susan, Melissa, is there any vendor EMR that's yet to take some sort of pilot that's knowable that we know of? Is Oracle Health try to land somewhere in the stratosphere within the correction system? Any user case scenarios?
I mean, I'll tell you what I know, and I'd love to hear from Melissa because I think she's maybe has touched more. I mean, hopefully, I'm not building you up to information you don't have. But.
I mean, you are.
Here's what I know, is that I have heard a bit about like next gen in practice in some of the like state level. I have heard about, so like CoreCivics leverages Veradigm Allscripts, which is huge. I do know that Oracle Cerner has won some contracts for state correction systems that are in stages of implementation. So I think they're there, and I don't think it honestly, I don't think it matters which
Yeah.
technology. It's not about the technology. It's the governance, it's the process, it's the workflow, it's the people. It's all of those things that will make it successful, because any of those products and could work well or work terribly, depending on how they're implemented and used.
It'll work better than what's currently being done. That's
Well,
for sure.
there's that.
I
Win.
mean,
You're
I
winning.
could
You're winning
say.
with any of those over nothing. So that's
Specifically, seen mainly SDOH platforms being used or being purchased now for specific county regions within the jail systems for closed loop referrals, and being able to accommodate, food pantries and things like that, and making sure that their individual has actually gone and seen whoever they were referring to within that closed loop referral system.
So do you know more about, just going back to the reentry, that, when I last left my state scenario was a couple of years ago, where I got to sit on a couple of meetings where the state had some reentry staff that focused on this, and then the managed care entities worked with them, and they were getting some good things built, but I hadn't heard much yet about social care at that point. And I'll just say, one of the things I noted then when I went to go back to ask more questions to the reentry staff, they were no longer there. These are open positions. They turned over. So I guess I'll go back to municipal government is hard. The retention on staff is.
I was going to say the turnover is very, very frequent, unfortunately, and it causes for inconsistency and gaps and people to fall through the system. So I know that is a thing that they are working on in most counties for them to be able to have the retention rate stick, so that this isn't a consistent issue.
Well, what would you, as we're kind of coming towards the end of this Justice Jam for Justice, Bring a Friend series, which is really awesome to have you, Melissa, Susan, on sharing about these passions that you have for really, what would you like to happen? I mean, I know this isn't a one-time thing. This is a project that's ongoing. You're moving a lot, doing a lot. But if there's something that we could land on today as a takeaway, as what would that be?
I mean, to Susan's point earlier, don't forget them. Like these are people that made mistakes, that are individuals that are going to be in our everyday population at some point. And if they're not, they're surrounded by the ones that are not being released are surrounded by individuals that will eventually be released. And making sure that I'm a big advocate for mental health within the system. I feel like it's completely overseen and it's not taken advantage of enough. And I feel that in the end, it's going to be a major issue for those that are leaving the system. And to point, obviously creating those standards so that those individuals are getting the proper care on the outside. I mean, without the standards and without the data exchange, things get lost. People are having duplicative testing, and those are things that are directly impacting us, and them and the families, and creating more of an issue and compounding that repetitively without any resolution. It's, I just want people to open up a little bit more, because I know that the population isn't necessarily the one that people ideally look at to try to, better. But in the end, like, they're people, and they deserve they deserve at the very least healthcare.
I'll take a little different direction. One being, going back to workforce, there's an opportunity, and I'll just take, I'm a longtime a HEMA member, so health information management folks or people going into programs like that. Think of this as a career opportunity, or at least how can people with really great expertise or education take what they have into this area, rather than some of the, not programmed to everyone goes to the hospital. Like, how can we as a workforce, as associations, serve to lift up that workforce. And then second, education, like how can, like a direct trust, how can we be a partner to how do we go to these maybe conferences or invite them to speak at ours? Like how can we open up so that we don't stay in a silo? So that would be invitations to participate and know that there are other aspects of our industry that we really need to call upon.
Well, I really want to thank you, Susan and Melissa, for coming on today.
Oh,
Thanks for having.
Yeah.
And this has been so important to have these conversations that jam out on justice. And this has been our new series, Bring a Friend series, where we're really able to reimagine healthcare together. Thank you for joining us on Planetary Health First, Mars Next. Until next time, friends, peace out.